Thank you very much. I will be today focusing on what we're calling patient-driven adherence. I think there's a quote by Bill Gates, which is that the best way to predict the future is to build it. And I think that that is a lot about what we'll be talking today, is about how we think about developing and creating solutions that help us to engage patients and HCPs and the healthcare professional or healthcare system in more interesting ways. I'm driving this. So I come from a company called VERYDAY. We are, as mentioned, a design and innovation company, working with lots of different clients over the last 40 years. And I would say one of the things that has made us most successful is the way we approach our creating solutions. We firmly believe in the importance of patient and people insight, and everything we do stems from this idea, even from the beginning when we were focusing on more universal and inclusive design. So today what I'd like to do is take some of the learnings we've had of the last 40 years from working with healthcare and talk about this idea of the future. So our position is that the patients are the only ones who have the whole view of their condition and treatment. Patients' expectations are shifting. And I think this is exactly what Anna was talking about. We think that while, of course, we can have a tool that tells us what our heartbeat is like or our blood pressure, the reality is that we're the only ones currently who understand the emotional state we're in. We are the only ones who understand the range of pills we have access to, or not. Maybe we don't know this. But right now, we are the persons who have the greatest view of our health. And we really need to think about ways we can leverage this. So this is just a point of view, and of course, it may not be absolutely correct, but we'd like to just take a stance and see where it goes. Currently, we believe that the focus is on the product, the pill as a driver. And you can talk about this pill, or you can talk about this as the app, what have you. But the reality is that we're in a situation where we sort of say, here's what we have, take it or leave it. And as a result, we end up in the situation where we have to constantly tell people what we need to do, what we intended it to do, what we hope it will do for their lives, and may or may not, depending on their situation. That's where we currently are. We know that because we've been working with companies for the last 10 years on this, we know that in the near future, many products and solutions, including drugs, will be based on the idea of needs and insights, which is, of course, a much better place. And this means that we're getting slightly more patient-centric, patient-facing. And at the same time, we also know that we're working with lots of folks who are doing this more co-creation. And this is a much more engaged method of interacting with patients, the healthcare system, and HCPs. And of course, that's really important to creating more relevant and tangible solutions. But it still takes the sort of perspective that we're going to create based on what we know. We're going to create one solution. So I think I just read a quote the other day that said something like, we treat healthcare like an answering machine, which is that we sort of decide what the message is and we hit play over and over and over again. And I think that what we're realizing now that healthcare has to be much, much more individual. And it's really expensive to think about doing that from our perspective, from the industry perspective. How do we make medicine more personal or individual? How do we make care more individual? But there is this thing where we have the opportunity to really think about how we empower patients to take more responsibility from creating an individual perspective on their health. And we know this is happening. We know that there are patients going out there and creating tools that solve their problems. And we also know that there's, but I would say conversely, we also know that there's plenty of patients out there who don't actually want to take control of their lives. And I think the challenge that we have is that while we make it very, very easy to not have control, this is also costing us a lot of money because we're treating everybody the same. And as a result, we're not capturing what could be an opportunity to let people take themselves through the system in ways that are more effective and more efficient and more personal. So again, I think when we talk about engagement, we should not be talking about, as we typically do in the world of the industry, the healthcare industry, is like a way of engaging people in the way we think that they should be interacting with our products or our drugs. We shouldn't be thinking about as engagement as a means to an end of our own device. We really should be thinking about how we can engage patients in their own autonomy. How can we get them to care about their health? And as a result, sort of set them free on the path of engagement. I guess the reason why this is important, and to make it a bit more tangible, is some of these numbers. We'll talk about it now more as adherence rather than autonomy. So 90% of patients do not know if they are adherent or not. This is from a diabetes study, but if you just step back and think about this number, it's really interesting that 90% of the diabetics that were surveyed, and this is in the US, did not know if what they were doing made them healthier or not. So even those who did think that they know may or didn't feel the confidence to be able to say yes on this. I think this is something where we can actually step back and take a bit of responsibility. We can actually help people to know more about themselves, more about their health, and how they can move forward with things. An also interesting statistic there is 1 to 300 billion is spent in each year in the US on avoidable medical costs related to not adherence. That's the it's equal to or double the national Swedish debt. That's a lot of money every year spent on something we know we can prevent. So first, let's get some definitions down. When we talk about adherence, we like to break it down a bit. We talk about device adherence, which is knowing how to handle your devices correctly. And a lot of time and money is spent on this, including in the digital space. This is actually the big hurdle. Then there is regimen adherence, which is making sure people know how to take the correct dosage at the right time. And then there's lifestyle adherence, which is activities and behaviors that create a successful treatment condition. This is, I think, the way we typically talk about compliance or adherence. What I think we want to sort of bring to the table is that we have one more very, very important way of discussing and talking about adherence, which is the patient perspective, or I would actually extend that to the HCP perspective, much like Anna was talking about, and even the administration perspective. So a lot about adherence is about personality. So do I care, the way I cope, and it has just the fact that we haven't acknowledged that these are important in our overall care experience has created big problems for ourselves. So we know that we can start to narrow down on this and start to think about it from a patient perspective or HCP perspective through these 4 drivers. Call them access, simplicity, motivation, and support. And these are not surprising. In fact, we've talked about motivation several times already today. But what we have experienced is that, I'm just going to skip through this, that in the process of design, we've sort of realized that there are many ways we can design for adherence. So while these are drivers, access, simplicity, motivation, and support, there are specific ways that we can step back and ask ourselves, how can we improve upon and design for better solutions? And I'll go through each of these, and I'll give a small example from the industry, or from that's already existing, about how these are manifesting themselves today. So the first driver of adherence is access. So the current situation relies on people making their own connections. So what this means is that we create, we have, the way that the patients are currently asked to communicate or interact with the system, expects them to first contact several different people in the healthcare ecosystem. They have to decide whether the solution is right for themselves, and that is only if they actually know if they have access to the right things. So let's talk a little bit about how we might design for access. I think maybe, and again, I want to just reiterate, this is about designing for adherence. So we need to step back and ask ourselves, how can we design for convenience as it relates to access? I think a great example of this is this mobile insulin titration intervention study. So we're in the realm of digital health, but this is actually an interesting example of how we really need to take into account the context of our solutions in order for them to be successful. This study was done in New York City, and it was just published a couple months ago. And what they realized was, what the study is about this experience of titration, which is usually about 4 weeks of getting to your optimal insulin dose. And the typical, the status quo is that the diabetic is asked to take their, to come into a meeting on a regular basis into the clinic. And when they come into the meeting, they discuss their dose and whether it's been effective, and they make small changes along the way. This is what happened in the control group. In the study, what they did is they asked people to SMS their BG levels, and when they got them, and that they would respond to them via SMS. They would talk about them via SMS, much more text-based approach. So what's interesting about this is that what this particular study realized is that most of the people who have, or not most, many of the people who have diabetes in New York City are of a low income level who do not have access to smartphones. So this is actually, when you take into account convenience, a really important part of this is this idea of the individual. Who are you targeting and why? And so the result of this test, which is that you were basically using a digital tool to connect with the system, you had access to the same resources. If the person in the control group had a question, they could give a call. They were asked to go to these regular meetings. The study group was SMSing. They could go in if they wanted to, but the idea was that they would be saving money for themselves, saving time from work, or sorry, they were saving the cost of having to take a day off work. And the result was that 88% of the group who SMSed were able to titrate or find the optimal insulin dose in the first 4 weeks, or versus the other group, who was only 30%. Really interesting, very simple solution that is it's mobile, and it takes into account the personal context of convenience. And then I think when we talk about cost, I think we just have to rethink about how we think about cost these days. So the example here is about Indiegogo, where people are actually crowdsourcing money for their treatment. So we've always talked about the problem with access to treatment is having the money, but now we can actually think about how we might engage with people in new and interesting ways to get money. All things we can design for. So the second driver of adherence is simplicity. So the best or the easiest way to convey this is that yours, whether it's your app or your medicine, or if you're in the hospital situation, your infusion method is probably not the only one they have to sort of figure out how to do correctly. So a really important part about creating adherence is about how do we work as part of a bigger ecosystem and make that simple. How we do that is through both whole patients and habits. So when we talk about the whole patient, we are really talking here about understanding and taking responsibility for the idea that we are a little bit complex, and we have to be able to acknowledge that we should open up a bit. At least ask questions about whether this interrupts something in my current schedule or my current way of living. And as a result, it also asks us to talk a bit more about trade-offs. For example, when we say, like, support all efforts to be adherent. Not everybody can do everything as you suggest. So how do we figure out the right spectrum of trade-offs? And make that clear. And that's probably the hard part, is making that clear. Habits. This is probably my favorite topic. And my favorite example for this is, sorry, I would go back to the, my favorite example of habits is this idea of what is it more, is it easier to, is this idea about charging, actually. So I worked a bit with batteries. And the idea that you actually have to charge a battery every 2 to 3 days means you end up running out of battery life a lot more often than if you charge it every single day. Now, this is an interesting technical question. Like, we talk about this all the time, about what is most efficient and being most powerful in the front leading edge. But again, if we're about establishing habits, we need to really think about how we fit into people's lives in a more systemic way. This is about education and motivational triggers, and really helping people get there. And I think a great solution in that space has been PillPack. I'm sure it's familiar to most of you. And I think there's a Swedish version of this as well, which is about putting together or pulling together all the medications that need to be taken at one point in the day together into one packet, so we don't mix up or forget to take a particular medication. And how do we think about that? I mean, it's a great example about the idea of bundling. How do we think about applying this as a method to our current, how we are thinking about applying solutions or giving solutions to our patients? I have no idea on the timing. Okay. People don't want to be reminded that they are ill, and I think maybe the more damaging part about this is that we often blame patients for their non-adherence. And the reality is we have to really think more about how we help people to get involved in interesting ways and think about, as we say here, the root causes and desirability. So root causes, we're actually doing a bit of a survey on personality, because I think one way we can start to design for motivation is to understand what motivates different types of people. So if you are somebody who is goal-oriented and has a real desire to know a lot of information, the way we engage you is completely different than we would if we were somebody who's a bit neurotic or wishes to be protected from the idea or the future. And this is a really important point that we haven't actually discussed much, because we tend to design for the people that are willing to talk to us. Thank you. Is that the end? Okay. And then finally, we have experience data and collaboration. Thank you.
Thank you. And please sit down.
Yeah.
There's two of you, so
yeah.
Just so